One of the chief residents for the internal medicine residency program this year. And it is my pleasure this morning to start off Grand Rounds. I will go ahead and introduce our program director, Dr. Dominique Costco. She's program director of the internal medicine residency program, and she'll take it from here.
Good morning. Thank you, Ava. I appreciate the introduction. It is my distinct pleasure this morning to introduce my friend, Dr. Kimberly Manning, who will be giving our Grand Rounds. Dr. Manning is a general internist and hospitalist who serves as the Associate Vice Chair of Diversity, Equity, Inclusion for the Department of Medicine at Emory University School of Medicine. Dr. Manning is a professor of medicine and additionally serves as a residency program director for the Transitional Year Residency Program at Emory. Beyond her roles in the Department of Medicine, she has been a Society Small Group Advisor at Emory since their curriculum was formed in 2007. Dr. Manning continues to hold this position and currently co-leads the Semmelweis Society, which is one of the 4 academic houses in the School of Medicine. Dr. Manning's academic achievements include numerous institutional, regional, and national teaching awards. She has a strong passion for building and strengthening diverse clinical learning environments, as well as cultivating psychologically safe learning climates. In 2018, she was awarded the prestigious ACGME Parker J. Palmer Courage to Teach Award. At Emory, she has received the Evangeline Papa George Award, the Golden Apple Teaching Award, and the Yuha P. Coco Teaching Award. These are the highest teaching awards in the School of Medicine at Grady Hospital and in Emory's internal medicine residency program, respectively. Dr. Manning is an Inglewood, California native. She's a proud alumnus of 2 historically Black colleges, both Tuskegee University and Meharry Medical College. And she's a happily married mother of 2 teenage sons and 1 dog. She applies her lived experiences as a Black woman, mother, daughter, wife, and community member to all that she does professionally. Dr. Manning, welcome. We're excited to hear your talk this morning.
Thank you so much, Dominique. It's such a pleasure to be here. And I appreciate all of those kind words. I have no financial disclosures. Let's just jump right in. Oh, I should mention, I do have one disclosure. And my disclosure is that I'm not the authority on all things bias. I'm not a person who has figured this all out. I'm not a person who is now having a lived experience where I do not have any bias. In fact, spoiler alert, I do have bias. And so that is my only disclosure, but no financial ones. I like to start any talk with gratitude because sometimes we run out of time and miss the opportunity to thank people. And so today I'd like to just offer gratitude to your program director, Dr. Dominique Costco. I've known Dominique since she was an intern at Emory. And honestly, when I think of Dominique, the thing I think of is excellence. And this is a time when we really have to get innovative and think about ways to keep us connected. And so I have deeply appreciated excellence and also opportunities for connectedness. And this is just another opportunity for that. Also, in developing this talk, it's important for me to point out that there are stakeholders beyond our patients. There are our learners. And part of me getting proximate and better understanding why it's so important to work through bias, talk about bias, and get myself uncomfortable is for these individuals, our students, our residents, who will ultimately be deployed out to care for our patients. I want to start by introducing you to someone. This woman is, her name is Dr. Janice Lee. She's a professor of medicine at Emory, and in 2009, she became the first Black woman to reach the appointment of full professor at the Emory University School of Medicine, an institution that's been around since the 1800s. That would be followed in 2013 by Dr. Jada Bussey Jones, who happens to be my mentor, and followed then by Dr. Stacy Higgins, who mentors Dr. Costco, and followed by another woman by the name of Dr. Jennifer Christie. And so I want you to just put this number in your head, 38,074. That is the number of individuals, according to the AAMC, as of 2015, that were full professors. Of that number, 269 of them are Black women. And so as we think about things like bias and things that stand in the way of people reaching their full potential, there's an urgency for us to start to work through things that cause people to fall out of the pipeline or that cause the pipeline to be leaky. I should mention that that number just went up to 270 now. I'm proud to say, thanks to women like these. So, the question becomes, what then takes a medical student in 1995, like this one, and disrupts her from being in that number? Why is that number 270 so small out of the 38,000? And, I thought about when I got ready to prepare this talk for you guys, I started to think about, well, you know what, I could just go through all the literature that talks about, gender and racial bias with residency and all the things that happen there. And, I thought about, I could talk about learner assessments and how that is all impacted by our bias. But then, us medical nerds, we think a lot about the Bloom taxonomy and thinking about what people know going into things. And I sort of felt like, that might be something my colleagues at WashU know. And then, I thought about going through all the papers that show you how bias looks in the clinical setting, right? What it looks like this classic paper from Shulman published in NEJM in 1999, which looked at individuals presenting with symptoms of chest pain and their likelihood to get a cardiac catheterization. We've read the paper, we know what happened, right? We know that certain individuals, particularly the white men and white women, were much more likely to go to cath than the Black men and Black women. So I started to talk about things like that. And then the storyteller in me said, you know what I could do is just keep it real and just tell you about my own father, who presented to a hospital at the age of 55 with hyperlipidemia and hypertension and a strong family history with ST elevations, and who still did not get a cardiac catheterization until his daughter, a new internist in Cleveland, begged and pleaded with the cardiologist by phone to cath her father, who had a near 100% proximal LAD. I could do that. But instead, I think what I want to do is to really focus on us and our own bias and helping us to work through the transparent lens of my own bias, because it's easy to point a finger and tell you all the stories of how everybody else is biased. But to make this real, I think the focus here is going to be on my own bias to get you thinking about your own bias. And so we'll talk a bit about what implicit or unconscious bias is. We'll talk about when is it going to pop up? When is it going to happen? Why it's so important for us to be thinking about this. And I think we already have some baseline knowledge about that. But then how can we mitigate our own bias, right? So that'll be what we'll be talking about this morning. So I am a storyteller. Dominique will tell you that. So I'll start with a 60-second snapshot. So come with me into the emergency department at Grady Memorial Hospital. I was rounding with my team. This was pre-COVID. So, we were just out there with no masks. And I was meeting my team down in the emergency department for the last patient of the morning. And it was probably about 11:40 in the morning, very close to the lunch hour, very close to conference, and very close to a conference call that I had. And so as I got down to the emergency department, I beat my team there, and I was sort of standing there waiting. And this is what was going on around me if you were to take a 360-degree snapshot of what was happening. So here's me standing in the emergency department waiting. There's a Black woman who appears elderly, who's sitting in a chair with what appears to be a grandchild who's combing her hair. She has a Dora the Explorer comforter over her shoulders. She reminds me of my grandmother. There's a young white man who's in triage. I see him sitting on a gurney. He has on very nice clothes. He has on the newest Air Jordans. I happen to know that because I have teenage sons. He's holding a smartphone, and he's scrolling through the smartphone looking really bored. I wonder what he's doing at Grady. There's a couple speaking in Spanish. There's a man, he has an AV graft on his arm. He appears to be waiting to get hemodialysis. There's a woman who's sitting on his lap, and she appears worried. All of a sudden I hear this loud noise, and I look to my side, and there's a woman who is screaming in my direction. Her pale skin is diaphoretic, her hair is pasted to her face, and she's screaming and asking if I'm her doctor. I look down at my sheet and realize that I am not her doctor. All of a sudden, there's a cacophony of noise, and I hear a man getting pushed in by two officers. He has plastic ties behind his arm. His belt has been removed. His pants are coming down. He's approximately the complexion of my own son. He has dreadlocked hair, and it shakes every time he moves as the cops handle him. And I feel like it's a little too rough. There's a gender fluid staff member who waves at me and says hi, and I can't remember their name. There's two male surgical residents in scrubs, and they are laughing out loud. And then last, there's a nurse with a high BMI who comes to me asking for me to write an order on a patient. So these are all the things that are happening around me in that moment. Now, we talk a lot about implicit bias. That is that bias that we don't know is there, right? Or that we don't plan on having there. But we also have explicit biases. They're biases that we know off the rip that we already have, right? And so this Black woman who appears elderly, I do have a bias toward her. I know that. It's explicit. She reminds me of family. She's someone that I'm likely to protect. The young white male in triage, I feel my bias welling up there. I'm creating a narrative for him. The couple speaking Spanish, I'm from Inglewood, California. My neighborhood was predominantly Black and Mexican. I want to protect them. I feel an affinity toward them. The screaming woman concerning for psychosis uncovers my own bias toward those who are living with psychiatric illness, particularly schizophrenia. The young Black man in custody reminds me of my sons, and with all the things happening in the news right now, I am acutely on his side, and I'm not on the side of these guys. The gender fluid staff member, I think I feel neutral toward, but maybe I have an implicit bias. The two male surgical residents in blue scrubs, I think I don't have a bias toward them, but maybe I do. And then the nurse with a high BMI, I would like to believe that I don't have a bias in this direction. But the truth is that bias is so real that for all of these individuals, all of this could be impacted by my bias. And I want you to begin thinking about you and what you'd be feeling in this moment as well. And so as we talk about bias, we know that there's two types of main big buckets for bias that we think of. There's the explicit or conscious bias. You know what you like, you know what you don't like, and you're aware of it. Those are things that may align with your values or your upbringing. It can affect your behaviors, and it can be positive or it can be negative. But for the focus of this discussion, we'll be focusing more on implicit or that unconscious bias. And that's the kind that's not in our conscious thoughts. It's often related to social stereotypes. It might not align with your values or your upbringing. You may be really surprised at your biases. It's common and it can affect your behaviors. And again, much like explicit, it can be positive or negative. So let's break this down a little bit more to make it easier. So if you grew up in the US, if somebody says peanut butter, you say jelly because peanut butter and jelly go together, at least where we came up, right? And so that's how implicit bias works. It's just mental shortcuts. You see things over and over and over again, and they begin to have an association for you, right? It's ordinary for our mental functioning. It's unavoidable. And actually, it's really built from life experiences. The more you see something, one thing and another thing together, the more it starts to tell a story. And it's originally a survival mechanism, right? If you were a hunter-gatherer and an animal comes in your direction with teeth bared and snarling, you're not going to reach out to pet it. You may run, you may sense danger because in your lived experience, a snarling animal with teeth bared is dangerous, right? And so that was originally how that worked. And it may not align with your explicit feelings or your values. And that's the tough part about our implicit biases. It's kind of embarrassing to start to come out and say what they are. And some people will get the benefit of your bias, and some people will get a negative benefit, not a negative benefit, a negative outcome from your bias. So for example, if someone says white hair, you think an aging woman, right? That might be what you think. You associate white hair with aging. Except sometimes white hair is because somebody dyed their hair white, and it's not because they're aging. So sometimes these associations are wrong, and that is when implicit bias starts to create a problem. So we'll take a few moments to just think about some of your own bias. And I do want you during this time to be reflecting on your own bias, right? So as you look at this image, what does it conjure up for you? If these three individuals were walking in front of you, what would you think? Would you have bias welling up? Maybe they remind you of your favorite aunties, but maybe you have bias. What does this image conjure up for you? I know what it conjures up for me. What does this image conjure up for you? Maybe you feel really happy when you see this. Maybe it makes you feel safe. Maybe it makes you feel connected. Maybe not. And what does this image conjure up for you? What do you see when you see this image? Some might look at this image and see really angry Black men, one with a shirt off, with what appears to be some sort of marking on his shirt, more behind him that seem mad. Is it a gang? Who are these people? For me, because of my lived experience, I see members of a fraternity, Omega Psi Phi, that my dad and my husband belong to. And so the response that I have from my lived experience when I see an image like this is one of connectedness and actually one of joy, which says a lot about our differences, right? And how we come up. So our exposures and our life experiences really play into our biases. So how one feels about obese people, Black men, transgender, genderqueer, and non-binary persons, Confederate flags, all of that is shaped by our lived experiences. But the other thing to consider is that along with our lived experiences, what happens is that we start to have different life lenses. And our life lenses will cause us to have these blind spots that sometimes we don't even realize are there. These things that could be hurtful or perceived as wrong that we don't even notice because in our life experience, it wasn't there. So different life lenses can shape our bias. Here's an example. So some of you, if you're old enough, you'll know who this is. So this is a singer by the name of Meatloaf. And when I started my internship, y'all, in 1996, we in Cleveland, Ohio at Case Western, we all went to this dueling piano bar. It was like a really awesome intern, like bonding experience. And everybody was listening to music and singing along. They played things like Billy Joel and Elton John, which I was familiar with that, right? But then there was this moment where the first few bars of this song began to play by Meatloaf. And I tell you, every single person in that room stood on the bar, stood on their chairs, and they sang every single word to this song, Paradise by the Dashboard Lights. I had never heard it, y'all. And that's when I really recognized how different lived experiences can be depending upon who we are. And that is really applicable to bias, right? What we're seeing and living every day can cause us to be completely blind to certain things that other people just see as everyday connections. So I want you to take this little exercise with me. Look at this list and ask yourself, how many of these names are familiar to you? Art Garfunkel, Kai Ryssdal, Bonnie Raitt, Terry Gross, James Taylor, Carly Simon, Steely Dan, George Harrison. Now, some of you looked at this list and thought, I know who all these people are. And I would expect most people my age to know these people too. I mean, come on, Terry Gross? I don't know Terry Gross. But why would you think, what would you think if people didn't know who any of these people are? I know people who don't know who any of these people are, some of whom are college educated people. Now, let me show you something else. How many of these names are very familiar to you? Kiki Shepard, Jill Scott, Nia Long, Charlie Wilson, Florida Evans, Elle DeBarge, Donny Hathaway. For me, these are far more familiar than the first list. In fact, the first list that I showed you was one that I acquired slowly, but this was household for me. This was from my lived experience and my life lens and the lived experience of a Black American. And so as each of us think about the lists like these, you each probably have one that is unique to you and your culture and your lived experience that is different from those around you. And that plays into our bias. The next thing I'll ask you to do is to look at this list and just take a moment to think about the things that you do and don't strongly have to consider daily. For example, do you have to think about your race, your gender? Do you have to think about your sexual orientation, your gender identity? Do you have to think about your weight, height, or nationality? Do you think about being stereotyped by your race? Are you worried about your safety, your loved one's safety? So as we think about bias, right, and we think about being better stewards of our relationships with others and mitigating our bias, it's also important for us to continue to work through where our blind spots might be. What things in our lived experience have we not been exposed to? And what privileges do we have to not have to think about certain things? This is a really important exercise and list to think through. So, your own life experiences shape a lot. So for me, my life experience includes being the mom to these two boys. This is my mom here. This is how I often think of patients. My lived experiences makes me protective of certain patients. I also work at Grady Hospital, much like many of my colleagues. And then my lived experiences have some differences too. And again, I want you thinking through how our lived experiences shape the way that we think. I am married to a Black man, as I mentioned before. I have 2 teenage Black sons. I'm a descendant of slavery. And so the things that I think of and how I respond to certain things is related to that. I attended 2 historically Black colleges, as Dr. Costco mentioned. That shapes the way I think as well. I have sons who like to wear their hair in naughty hairstyles and Afrocentric looks. I think a lot about that. I'm the best friend to a same gender loving Black man. I think a lot about that. That shapes the way I think. Again, how I think of Black men and my association with Black men is very, very different than some other people's associations with Black men because of my lived experience. But like many of you, I'm a clinician educator, and I'm in this environment where all of these things that make me, me, are still there as I work with students. How does that look in terms of my bias? How does that play out day to day? So what we see also is we're in a space now where we see things in media that are different as well, right? So this is an image that went viral of a young woman on a MARTA bus in Atlanta, Georgia, who was speaking to another person in a way that was unfortunate. If you look up 6 o'clock news and Google that, you will see images like this. If you look up meth addict, you will see something like this. And these are the images that we start to have to connect to what people are. We start to create these narratives for people and stereotypes because of what we see. The ideal of beauty and what that looks like, what success looks like, what a perfect family, for example, looks like. These are images that come up if you Google such a thing. And then even things in the larger media, like someone like Serena Williams. This was a cartoon that was made about Serena Williams in response to her being upset with how things went in one of her matches. And as we reflect on people like McEnroe and others as we came up, we know that bias definitely plays a lot into how something like this even gets through an editor. On my way to Grady Hospital almost every day, these are images that I see. People who look like me under a bridge, who are living with homelessness. Again, though I don't want it to, it starts to become a narrative that I fall into as well. The messages that we get on the internet and in media also matter, right? So these are real Google images that I did. I Googled happy people. This is what happy people gets you on Google. There's one brother in there, he looks happy, but for the most part, it's pretty homogenous. If you look up beautiful women, with the exception of Halle Berry, who snuck in there at the bottom, this is the image that you got. You see my search right at the top, I screen captured it. How about poor people? Unlike those happy people and those beautiful women, they all are of color. This is what our images do. And this is really how our implicit biases start to work. These are these associations that we're getting. This is what you think of as poor, disenfranchised, right? And so with all of that, you're probably wondering, now, wait a minute, now, am I biased? Because like, I'm really a nice person and I come to lectures like this and I did the training and everything. Well, spoiler alert, we all are biased. Okay. And so just accept it and move forward. And so how can you really tell just what your biases are? So for one, many of you have heard of the implicit association test that was developed by researchers at Harvard. And it basically looks at associations. They show you something and they see how quickly you can associate two things. Greater than 10 million people have been tested. It does have some criticisms, but it does provide a lot of useful information about uncovering your own implicit biases. So for example, after you take one of the IAT tests, what it will do is it will show you what your preference is, and then show you compared to most people who took the test where it lands, right? And so this was my test for African American versus people of European descent, and it showed me here that most people who take this test have a strong automatic preference for white people, right? And so this is how the respondents are reported with each score, and you see where you fall within that. So some examples of IAT tests that are meaningful and worth having all of you take are white versus Black, young versus old, thin over obese, attractive over unattractive. And these are things that will play out in the clinical setting for us that we should consider. Now, here's another example of one of the Project Implicit tests. So this particular one looked at straight people versus gay people. And again, it lets you know what most of the respondents are having in their implicit biases. And here's the thing, many of the people who get these responses where they have a strong automatic preference for straight people, many of those individuals are same gender loving or identify as gay. So again, it may not align with your lived experience and who you are, but that's the thing about implicit bias. It's based upon exposures. So what is your prediction of yourself? Do you think you have any automatic preferences? I mean, I talk about bias all the time, y'all. So I kind of thought, okay, yeah, I got this thing beat, right? So some of the ones to consider, as mentioned, white versus Black, gay people versus straight people, obese people over thin people, cisgender, transgender, older, younger, dark skin, light skin. And so I was very surprised to see my own results. And I think a part of this discussion is also just a transparency about our own biases and then what that looks like in real life, right? I interview people for residency, I care for patients, I teach learners. This matters significantly. So I had a strong automatic preference for Black people over non-Black people or over white people. That one was actually not one that surprised me very much because of my lived experiences. I was surprised to have a moderate automatic preference for straight people over gay people. Given my lived experience and my connections with people, I just thought I would be somewhere in the neutral, but that was not the case. Obese people over thin people, I had a strong automatic preference for thin people. Cisgender versus transgender, I had a moderate automatic preference for cisgender individuals. I had a moderate automatic preference for younger versus older folks. And this is the one that I took like 10 times, y'all. I had to keep taking it over and over again. But I had a moderate automatic preference for lighter skin versus dark skin. And that was one that I have to say really caught me by surprise. But no matter how many times I took the test, I would like wait a month and take it again. I would get the same result. And that just lets you know how bias works. It doesn't always align with what we think. If you were to ask me what I thought as a mother of, as a wife to a dark-skinned Black man and with sons who are darker than me, I would think that my preference would be darker skin, and it was not. So what does that mean in day-to-day operations? It really means that, like you, I am just like a piece of tofu, and this world is the broth that we are floating in. So like tofu, we're going to take up all of the flavor of what's around us, whether we like it or not. And so I want you to know that bias affects who we protect, who we suspect, who we reject, and the data that we're willing to collect. Okay, so I want to mention just a few types of bias that were at play when I was standing in that emergency department, and that maybe you might have felt too as I told you those stories, right? There's affinity bias. That's that bias that you feel where you're biased toward those individuals who are like you. For example, if I know that I have a strong automatic preference for Black people, and I know that I have an affinity bias as well for people who remind me of my grandmother or of my best friend in medical school, those are things that can shape the things that I do. What does that look like if I'm working with residents or if I'm assessing someone, right? Attribution bias is where you assume that because of something someone does, that it's because of sort of stereotypical things related to their race or gender. For example, if someone is speaking loudly, you might have this bias where you believe that Black women speak loudly, and you might attribute them speaking loudly to the fact that they're a Black woman, and that's what Black women do, for example, right? So those are some things that can happen with attribution bias, or even something as simple as an individual does really well on a test, and you say, well, it's because they are, of Asian descent, because of a bias or stereotype there. That aligns also with stereotyping, which tightly is connected to stereotype threat. It goes both directions. We get these ideas of who people are, but also individuals will start to play into that stereotype because, again, of what they see around them. Racial bias is, it doesn't really require us to define it much. We know that it exists and is real. Disability bias is one that we don't talk about enough, but as we discussed that patient who was struggling with mental illness in the emergency department, I have to really wrestle with my own disability bias for that individual. And of course, gender bias is one that we have to think about all the time as well, that plays out often in the hospital setting, but also with our learners. And then blind spot bias is where you think you don't have no bias. You think that, you know what, I hear you, Dr. Manning, all of this stuff that you're saying, but you know what, I'm not really biased like that. That's not a thing that I do. And so there are things that we can do to mitigate our bias. So first of all, there's institutional strategies, some things like implicit bias training. I'm sure that at WashU, that's something that you all have. But the more implicit bias training that we have, those are strategies that help. Objective hiring practices, what our search committees look like, structured interviews, how we review outcomes for evaluations and promotions. These are all things that can help. And then promoting bias literacy, conversations like this that get us having the conversations and really thinking more about what do these biases mean. And then there are the individual things that we can do, right? First of all, there's the implicit association test. I walk into my day now knowing about my explicit biases that I already knew, but I also now know more about my implicit biases as well. Reflection by exercises about our biases are very powerful and impactful ways for us to further to mitigate our own bias. Perspective taking and empathy building, thinking about, okay, what if that were me? What if I were in this situation? Counter narrative exposure, being exposed to individuals that are counter to the narrative that you may see in greater media. For example, if you turn on the news and you see Black men in handcuffs, right? Or you see all the images of Black men out during a protest, that can affect how you think. But if you counter that narrative by spending time with Black men who do not fit any of those things, reading things about Black men or looking at things that counter those narratives, those are things that can help as well. Discretion elimination is important as well. We've heard certainly of studies where those things that tap into our emotions are removed. There's a really often spoken about study that looked at people being auditioning for the symphony and having them behind a curtain so you could just only hear the music, right? Even removing their shoes so you can't hear the heels clicking on the floor and knowing it's a woman versus a man. So those are some things that can help individually. Building new associations is going to be important, but also just being okay with awkward. This image here is an image with a student that I worked with. She was the first trans woman that I ever worked with in a clinical setting. And there were a lot of missteps that I made. And fortunately for me, she was very patient with me, gave me a lot of redirection, and it changed the way that I interact with individuals who are transgender. Here's another exercise that I want you all to think about as well. This is something that I do with my teams. It's called bias rounds. And what we'll do is we'll sit down at the start of a day and run our list, but run our list specifically for bias. We'll say, okay, where do we think that we're at risk for bias? And I usually start as the leader of the team by uncovering my own biases. I'll say, this could come out wrong, you guys, but on my IAT, I have a strong automatic preference for thin people over obese people. And I noticed that we have this patient that we still need to see. He's 400 pounds. And and I think we should go see him first. I don't want to see him last because it may be a biased landmine and he may not get the best of me. So adapting your day to sort of mitigate your biases and keeping that dialogue open and transparent is going to be important. And I'll tell you a little bit more about what I mean by those biased landmines. So biased landmines are these moments where the things that happen where your biases are likely to come out in action, right? So certain emotional states, if you are really upset about something, for example, many of you saw that image of Amy Cooper in Central Park. She was under duress. She was stressed, and under that emotional state, her bias that probably for her was an implicit bias, it came out in the form of her calling the police on Mr. Christian Cooper, right? When something is ambiguous, when you aren't really sure what the rule is on it, bias can come out there. Low effort cognitive processing, where you just keep doing the same thing over and over again. For example, if you are scoring posters for a national meeting, if you are on your 10th poster in a row, though that shouldn't be low effort, it should be high effort, there's a point where you may need to just stop and walk away because you're going through the motion so much that bias could kick in. Distraction, of course, fatigue, being hungry. Hungry is a big bias landmine, y'all. So you need to eat. And then rushing and high pressure. So I just want to show you this, which really kind of encapsulates all the things that I mentioned here. This is from a paper published by Jasmine Marcelin in the Journal of Infectious Diseases that looked at bias. And this was showing some strategies to mitigate bias. We already mentioned in the orange here, there's sort of the leadership commitment to culture change. There's those meaningful diversity training, sort of kind of like what we're talking about now. Those individual strategies, of course, that self-reflection on your personal biases, right? And then questioning and actively countering stereotypes. I already mentioned that. And then from both a systemic and also an individual standpoint, there's those intentional diversification of your experiences, right? Broadening that life lens, cultural humility and curiosity. Remember that awkward piece that I mentioned? There's just gonna be stuff that you don't know, right? That list I showed you of names, you might not have heard of any of those people, but conversely, I might not have heard of some of those people either. And so us having that cultural humility and not othering people by assuming that everyone should know the thing that is typical of our white heteronormative country is important. And then mentorship and sponsorship will always be important things to mitigate bias. So I want to show you this, speaking of hungry. This was a study that looked at about 1,000 judges, and they were doing parole hearings. And basically their daily schedule included meal breaks. And here's the deal, right before it was time to eat, people were much less likely to get parole. When you're hungry, you didn't get parole. But after you get lunch, it looks like 65% or more were more likely to offer parole. So what does that say? It says that we may be much harsher on people, or a bias may come out, right? More with something as simple as just being hungry. Okay, so I'm going to give you an example of this in real time for me in clinic. So I was in clinic at Grady. Dominique remembers this very well. It was busy clinic. I was precepting residents in the clinic, and it was about 11:50. We were almost done with the clinic session, but still a little bit busy, and things were kind of chaotic. I was working with a colleague who probably wasn't working so fast, so I was a little frazzled, a little overwhelmed, and in comes one of our patient access reps who asked me, hey, this patient is 30 minutes late. Can we check her in? And the question that I ask is, hey, who is this patient? What's her name? And the access rep tells me that the patient is a person by the name of Jonquavius Moore. Okay, so when I hear the name Jonquavius Moore and it's 11:50, I'm hungry, I'm frazzled, I'm busy, I'm rushed, right? I am near a bias landmine. But what happened here, and I am not proud to say, I said, she needs to reschedule. Because I decided in that moment that Jonquavius Moore is the name of a person who's probably about 30 or less. And if you're 30 or less, you're a 30-year-old or less Black woman. I mean, why are you late? Why couldn't you get here? You can catch the bus. You don't walk with a cane. I didn't even look at Jonquavius Moore's chart. I'm making up the name, by the way. I sat there for a moment and I thought, and I said, wait a minute, this is not based on anything. Now, if we flip the script and this very same thing happened and they say, Willie Mae Jenkins is 30 minutes late. Now, Willie Mae, now that's somebody's grandmama. Now, Willie Mae might have been relying on somebody to drop her off. Willie Mae, may be in a wheelchair. Willie Mae needs to get checked in be seen, right? Well, as it turns out, Jonquarius Moore was somebody who had been in the Coumadin clinic, who had multiple medical problems, and the Coumadin clinic ran over, and she was frantically trying to get to her appointment. And Willie Mae has a history of being late all the time. So it's important for us to unpack our own biases and know if we're near a bias landmine. I was hungry. And because of that, and frazzled and all these things, I got up and walked up to the front. And that's when I found out more about why Jonquarius Moore had been late, to really come up with a strategy to help her get checked in. So that's what that looks like in real time. And if I wasn't aware of the fact that I'm in a bias landmine right now, I'm doing something ambiguous, there isn't like a really good, clear rule, because ultimately it comes down to what the attending thinks. That's what bias looks like in real time. And it can be something very simple as making somebody check in later or reschedule, or something like going the extra mile for a patient. So checking our emotional states is important. That ambiguity I mentioned, low effort cognitive processing, distraction, fatigue, hunger, and then rushing and high pressure situations. Those are times when bias is going to come out. So back to that emergency department, asking yourself, what was I thinking while I was down in that emergency department? There are things that you can do. You can check your emotional state. You can manage your known triggers before seeing patients. Slow down. Things like this, telling trusted colleagues about your biases makes a huge difference. Adjusting your schedule to mitigate biases. And then I like to just call myself out, which is why I do bias rounds, because what happens is it creates the psychological safety for other people to be honest about their bias as well. And so for me in that day, I already mentioned to you that some of the areas where my implicit and explicit biases were at play would likely impact what I did in that moment. And as a role model for residents, I have to consider that. And you have to consider it too in your own time. Think about, what did you feel when you saw these things, right? I want to leave you with a few things, and that's this. This is a paper from Academic Medicine that looked at talking about bias to being about change, right? They use something called the Transformative learning theory, which has been around since the 70s, which talks a lot about how we learn something and actually then change. So the Transformative learning theory starts with disruption and a revised interpretation. So some of the things I've told you today, I hope it has disrupted the way that you're thinking. You think about, there are things in my life lens that could be different than Kimberly Manning's life lens. That leads to a critical reflection, some dialogue, and then action. We change our behaviors, right? And so for things like microaggressions, it's worth mentioning, because no bias discussion is complete unless I mention this. Bias can also lead us to do things and have actions that can be hurtful both to patients and also our learners as well. Some types of microaggressions include microinvalidations, something that we call micro insults. So the microinvalidation is where you sort of assume that you miss something altogether. You are completely unaware of something happening that relates to another person. Like one example I think of is when I was in elementary school and they used to call the crayon that was peach colored, everybody in the class called it skin color. And that wasn't the color of my skin. That's a micro invalidation of me, who I am. Micro insults are sometimes those ones that say things like, hey, oh, you speak really good English, or you're so articulate. I can't believe you went to a historically Black college. You could have gone anywhere. Micro assaults are sometimes a little more deliberate, but know that intention does not have to be a part of it being a microaggression. And that is a word, microaggression, that can be very controversial for some people. But I'd like you to think of the word microaggression as one that is disruptive. Think about it in the place of that transformative learning theory and how it really shapes the way you think. I'm going to show you this really quickly as we draw to a close. And this is about microaggressions.
For people who still don't think that microaggressions are a problem,
oh, you're so well spoken.
just imagine, instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. nice. But if you're only bitten every once in a while,
No, where are you really from?
Cleveland?
sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date,
Oh, your English is so good.
Excuse me?
going grocery shopping,
You know, everything happens for a reason.
I'm just buying apples.
commuting to work,
So when are you gonna have a baby?
watching TV,
We have to keep the Redskins' name. It's part of our culture and history.
or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Give me shopping advice. I love Cher too.
And getting bit by mosquitoes every damn day,
Can I touch your hair?
multiple times a day,
So pretty. Can
Can I touch it, please?
Can I please?
is annoying. That makes you want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares?
Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
Okay.
For people
So when microaggressions happen, it's just worth mentioning what we can do in those situations. So there is a direct response. You can distract and change the subject. You can delegate to another person. You can delay, which is come back and check on the person afterwards. But I want to draw your attention to one other thing, which is a display of discomfort. We used to refer to this as the 4D approach to upstanding, but we now I like to think of it as the 5D approach. This display of discomfort is a time when bias comes out in the form of a microaggression. There's things that we can do right in the moment, right? So display of discomfort, I think, is one of the easiest things we can do, because one of the most hurtful things when you're on the opposite end of bias or a microaggression is when you feel the loneliness of no one else noticing. So you can be a little subtle about it, a little less subtle about it, or even you can go all the way here. But these are things that we can do in the moment that can also autocorrect people from their bias coming out. So I just want to give you one last example. This is a student, MJ. MJ was a trans woman who's rotating on your team, and the team each day would say things to MJ like, "Oh, you probably know how to Vogue. Oh, do you watch that show, Pose? Oh, hey girl, yes." And all these exaggerated things that they thought that maybe MJ would want to do. In fact, MJ doesn't have a TV. She had never watched the TV show Pose before, wasn't really too familiar with it, but it kept coming up. But over time, it started to become a thing on the team. Every time she would present, somebody would say, "Yes, girl," or something like that. And it became an issue for her. So the question are, what biases are at play? What are the microaggressions? And how can you be an upstander? So we know that some of the biases that are at play is there were these stereotypes that were being played out about MJ and about what is thought that she should do, this expectancy bias. Some of the microaggressions come across in the form of these micro insults about assuming who she is and kind of making a narrative for her without allowing her the luxury of being an individual, and ways that you can be an upstander. Again, remembering those D's, you can display discomfort. You can be direct and say, "Hey, let's kind of stop assuming that about MJ." You can delegate. You can come to the attending later and say, "Hey, I want to talk about what's happening with MJ." You can delay, come back to MJ and say, "Hey, are you okay? I noticed these things were happening." You can distract. "Hey, let's get off of that and move to something else." Or you can do a combination of all of them. These are things that we can do when we see bias come out in the form of microaggressions. So beyond the IAT, making the implicit more explicit to you, ask yourself these questions. Who am I? What am I afraid of? What am I afraid other people are afraid of? Who am I trying to protect? Who am I trying not to protect? What am I mad at? And I'm mad at some things right now, y'all. What am I sad at? I'm sad about some things right now, y'all. Who and what makes me feel at home? Who and what makes me feel lost? What makes me feel awkward? Here's your homework. If you have not done an IAT, go to Project Implicit and do IAT testing. I have no connection to IAT. I just think it's a useful tool. Watch out for blind spot bias. Don't think you don't have bias, you do. Acknowledge your biases, implicit and explicit. If you are a leader, it is powerful to come right out in the open about your bias. Talk to trusted colleagues about your biases. It makes them real, takes you out of hiding. Check your emotional and your physical state, those bias landmines, and adjust workflow when you can, because sometimes you need to. That patient that you know you have a bias against, that isn't the patient to see right before lunch. That might be the patient to see after lunch. Take a moment to reflect on an incident and keep trying. In summary, implicit bias is pervasive, but we all have it. They're environmental factors that cause our biases, our life lenses, right? And they don't always align with our values. Implicit biases can affect our actions and our decisions, and that impacts our patients and our learners. And implicit bias can lead to microaggressions, which may be that thing that keeps a young Black medical student from becoming part of the 38,074 full professors. Implicit biases can be mitigated through individual and institutional strategies. Awareness can be powerful, and associate with diverse groups. That helps. And individual relationships matter. This is me with my friend Leslie Miller. I'm a Black woman from Inglewood, and she is a white Jewish woman from upstate New York. We're very good friends, but we have broadened each other's life lenses dramatically. Remember, bias affects who we protect, who we suspect, who we reject, and the data that we collect. Thank you.
Thank you so much, Dr. Manning, for that wonderful talk. We can go ahead and proceed to a little bit of question and answer time. We have about less than 10 minutes here. So everyone who's attending, please feel free to send in questions through the chat or the question and answer tool. I'll go ahead and get started with one question. Thank you for providing us all those tools for dealing with our own implicit biases, as well as responding to microaggressions that we see. And so my question is, sometimes we experience these microaggressions in the community, or we see it maybe even with family members, and oftentimes being physicians, it's with patients. Do you feel like you utilize these 5Ds differently in a patient context as opposed to some other encounter of a microaggression or a moment of bias?
That's a very good question. Patients are people. And so that's the first thing that I always tell myself. Yes, I do apply the 5Ds to that. So one example, I had a South Asian resident on a student on my team who was talking to a patient, and the patient looked at my student and said, "Dude, do you even speak English? Dude, what is your name? Dude, what is that name? Do you even speak English?" And I chose to use the D for direct. At that point, I was the attending on the team. In the moment, I said, "Sir, that's not okay. This is a student on my team. And if regardless of where he's from, he's a part of the care team and here to care for you. And we will not accept that." Now, I was the attending. It might be different if I were a co-medical student, right? So a co-medical student could use a delay, could step out and then debrief with that fellow peer and say, "I saw what happened. That was not cool." Because one of the most hurtful things in my lived experience with microaggressions is the loneliness that no one notices. Like something happens and you're like, "Am I the only one who heard that?" So just an acknowledgement. But I tend to be direct in the hospital setting with patients. There's also things systemically that we have signs that speak about our culture and what we accept and what we do not accept. So those are other things on a systemic level that can help.
That's great. That's great to hear. I love to hear that advocacy happening for the trainees as well. And then another question that was submitted by an attendee kind of talks a little bit more about a change in the roles here. So how do you address microaggressions when they happen from a superior or someone in a leadership role?
Mhm. Yeah, I had so many slides I wanted to put in here, but I was like running out of time. So first of all, yes. So the microaggression, sometimes a microaggressor is you. So the 5Ds can still apply. You can auto correct yourself, right? And still use delay. I noticed that I said this to you, and that was not cool. I recognize that was a microaggression. So if it's somebody senior to you, what you use in that situation is that that delegate D. The delegate D is where you go and speak to somebody else about it. Example of that is I had a student who heard a faculty member say that one of her co-students should be playing for the Lakers with LeBron because he's so tall instead of being in medical school. It was a dean, and so that student came and told me. Again, I'm more senior, and so this was somebody that I knew. And I was able in confidence to go and talk to them about it. And then that person brought the student back in to have a conversation about it and to apologize. And so, that's the other thing. We have to extend grace to each other. That's why I show you so many of my own foul ups, bleeps, and blunders, because it's really easy to tell you a whole bunch of stories about everybody else messing up and not tell you the stories about me sticking my foot in my mouth, with my trans student over and over again. Who extended me grace. So I think that is a really critical piece here too, that we have to remember.
Thank you for that. Another question here, do you recommend that we change our EPIC EMR standard patient note template to omit patient race in the title line? I would think that this could promote bias at the initial patient or even note encounter.
Yeah, there's lots of data about using race in the initial data line. And I actually think that culture has sort of shifted away from people doing that. But where it pops back up? It pops back up in the problem representation. I noticed that nobody says it at first, but then you get to the problem representation and suddenly the person is Black or something like that. I should also mention that I do notice that a lot with immigrant patients, that right in the first tagline, it's that they tell you that the person is an immigrant or from Guatemala or from wherever they are, which immediately inserts some bias. Depending upon your system, I know a lot of people have templates that are individual templates. I do favor not having race involved unless, you're describing skin as a dermatologist and there's a specifically unique thing to Black skin. In that point, you describe it in the physical exam. Otherwise, I think there's enough data out there that says that it's not a good idea to include that in the first line.
Great, thank you for that. One question here. In your opening comments, you mentioned dealing with your own uncomfortableness in the space. Can you expound on this a bit more? Because typically we think of the listeners experiencing discomfort and not the presenters or the leaders in this space.
So if I'm understanding correctly, this is about my own discomfort with talking about my own bias. I mean, because I want you guys to see me as this really good person, right? I would like to show up at WashU as a visitor and they think, wow, this is just the most empathic, most woke person in the whole world, but I'm human. And so that does make me uncomfortable, right? Like when I do bias rounds with my team, I think to myself, this could lead to judgment, right? But actually the opposite has happened. What it has led to is psychological safety for people to be honest about their bias, and then more opportunity for us to counter narratives together. But it is uncomfortable to show your clay feet to anybody. We want a gold star. We want to seem like we're nice people. And I think you can be a nice person, but own your bias. But it is a vulnerable space, and vulnerability is always uncomfortable.
Well, thank you for being vulnerable with us here today.
I think we have brown hat on today.
Yeah, I think we have time for maybe one more question here, so I'll pick this one here. You mentioned bias rounds. This is coming from a trainee. How can we implement bias rounds into our daily routine? In other words, how does this look in practice, and how do you initiate this?
Shout out to the trainees. I love trainees. So thank you for that question. So it's simple. Basically, I print out my list. I'm gonna be real concrete with you. I print out my list. We sit down. We are getting ready to round as a team, right? And I'll be like, okay, guys, we're short call today. It's a crazy day. I'm teaching small group at 3:00. We have grand rounds at noon. There's a lot of things that could be like some bias landmines, y'all. Let's run this list for bias. I'll start and I'll look at the list and I'll be like, okay, so first of all, we have 12 people on this list, and this patient right here has, is in custody, police custody, and I'm concerned that the police custody, combined with the fact that this is an obese person, could impact the way that I deal with the patient. Why don't we go see that person first? Anybody have any other bias that they want to work through? You know what, Dr. Manning, I'm worried about blank. And so we'll go through the list, or we'll go through each name on the list and say, do we think there's any concerns or bias at play here? And those are things that honestly, that we just bring it out in the open. On the busiest days, I find it to be the most important, mostly to restructure what your rounds looks like. For me, I tend to mostly do that with patients who are, I'll even say, like, on a positive note, this lady is 80 years old and is a Black woman. We have 12 patients to go see. And my affinity bias toward her could cause me to spend too much time in her room. So y'all got to keep me on task. It'll be something like that. So it doesn't have to all be negative things. It can be things that cause us not to offer equitable care to everybody. So that's what it looks like for us.
Thank you for
and then it normalizes it. It normalizes it. So that's the thing. You want a discussion of bias and to be normalized such that when it's time to be an upstander for somebody and call out a microaggression or speak to somebody about it, you're in such a culture of bias discussion that it ain't even a big deal. You're like, oh, dang. Most of the time people start auto-correcting themselves once this becomes sort of a part of your culture, of your team.
Thank you so much for giving us that practical skill set to take with us in rounds, even starting today. Hopefully we can start doing that here. So in respect to your time, I think we'll go ahead and wrap things up here. Thank you again so much, Dr. Manning. Thank you, Dr. Costco, for helping us get Dr. Manning to virtually visit us at WashU today. There were a lot of questions. I love to see that everyone was very engaged with you this morning, and this is something that we will certainly continue to keep talking about.
I appreciate being here, and I appreciate you guys thinking with me. I really do. I see there were lots of questions. I wish I could have answered them all, but I want to charge you to ask these questions of each other, have the conversations together, keep it going, and then don't forget your homework, take the IAT, and then do some reflection and thinking about your own bias. Just because I am a Black woman from Inglewood who went to HBCUs does not mean that I don't have bias and that it doesn't come out. I do, and so do you. And so we just all have work to do.
Thank you again, Dr. Manning.
Bye, you guys. Thank you.
Thank you.